Hello everyone, my name is Brian Robson. I'm the Executive Clinical Director here at Healthcare Improvement Scotland. And welcome to this, the final in the 2015 series of the QI Connect program. This is the 18th session since we began last year. This series came from a request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. We make the sessions short, accessible and recorded to allow access at a time that suited them. And our community has widened well beyond clinicians, and you'll find out well beyond the shores of Scotland. And just before we start today's speaker, I'm going to hand you over to Jennifer, who's going to tell you a little bit more about the use of WebEx. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon, everyone. Thank you for joining today's session. So just a couple of housekeeping slides to get us started. If you please use the chat function, and I'll just talk about that in a moment. If you have any technical difficulties with not being able to hear the presenter speak or keep losing connection, please message the events manager using the chat function or press *0 on your telephone. In the conversation, if you can just click on the chat icon that you'll see just circled in red there, and that's the important part. So if you can just select all participants from the drop-down box, type your message and then send. And we really do want the session to be really interactive, so please keep your comments and questions and ideas flowing throughout the call. So is the fun interactive part of the session. So we want to see where you're all joining us from today. You can just click on the pen icon. You can just see circled under the Quick Start menu. And then the arrow icon on the left-hand side, again circled here. And then just click on the map where you're joining us from. Fantastic. I'm going to hand you back over to Brian. Oh, there's a few. Sorry. I'm just going to hand back over to Brian, who's going to talk to you a little bit more about the Connect series and the organisations and countries now linking in.
Jennifer, and thanks to everyone who's joining in on the call from the UK and also from Singapore and further afield. When we started this series, we had no idea how successful and how attractive the series would be. However, as you can see, we're now reaching more than 300 organisations across the world who are regularly signing up for the QI Connect series, and we're absolutely delighted with that. I will keep the interactive nature of the programme working at the competition time, so stay awake. I'd like you to, again, use the function that Jennifer highlighted to you, the arrow function. And as you'll see on this slide here, our global reach has reached more than 45 countries. And we have no new countries joining us today, we thought that we would have the final prize for 2015. And what I'm going to do is I'm going to name a country. And if you could put your arrow as quickly as possible on the country's flag that I name. And we've chosen this country because they've regularly signed in live, despite the time difference, and they've supported us throughout the whole series. So many countries have. But today's country, are you ready? Today's country is Singapore. Well done! Congratulations, thank you so much for that. Well done. It looks as though many other people, including Laura and Chris and Jared, all knew the answer as well. Oliver found the top of the page. Well done, Oliver. At least the arrow is working. Well done, Jayla. Wonderful for you to identify the country. So we're absolutely delighted with that global reach, and we're looking forward to extending that even further in 2016. Jayla, there's a QI Connect mug coming your way. Congratulations and thanks very much for taking part in the small competition. Again, we started the QI Connect series. We had one page of logos. We stretched to more than 9 pages of logos of organisations that regularly sign up and connect and use the QI Connect. We call these people the QI Connectors, so welcome to those joining the call today. As always, we are delighted with having more than 27 universities joining us through the QI Connect series. I went to some new participants today from Saudi Arabia, from Brazil, and from North America, from the Dartmouth Hitchcock Medical Center in New Hampshire. Welcome to you. Welcome to the today, and for joining our series next year. We are delighted that the recordings that we take of the QI Connect series are being used all over the world after the event. And this is an example from Coate, our friends in New Zealand, who initially flagged up just how useful these recordings are. And recordings are very easily accessed on the Healthcare Improvement Scotland website. And we are now in Healthcare Improvement Scotland ourselves, and through our improvement communities locally, we're now carrying out learning bites where we sit down, listen to the pre-recorded call, and have a discussion in the room around what our speaker was saying during those calls. So great job with our team in Healthcare Improvement Scotland bringing that together. I'm also delighted as ever to have the International Society for Quality in Healthcare, ISQA, using the QI Connect materials as approved resources for their wonderful fellowship program. Shout out the small but perfectly formed QI Connect team here at Healthcare Improvement Scotland. You've heard from Jennifer, who put the whole show together. Carmen, who organises all the administration and all the certification for your CPD, your continuing professional development, and also Ross, who's our data analyst, but also runs all of the connections during the call here. So that's our small but perfectly formed team. Joining that team today, we're absolutely delighted to have Winnie Burke, who is Strategic Inspector at the Care Inspectorate here in Scotland. You'll hear from Winnie later on today, because Winnie is going to be asking the question of today's speaker. It's with great delight that I introduce you to today's speaker. And before I do that, I just remind you to please tweet as we go along today, and follow us at both the hashtag and the Twitter address you can see on screen just now. Brings me to today's speaker. Absolutely delighted to welcome Dr. Tracey Cooper. Tracey is the Chief Executive of Public Health Wales, and prior to joining Public Health Wales, Tracey was the Chief Executive at the Health Information and Quality Authority, HIQA, in the Republic of Ireland. Tracey has also been working with us very closely in Scotland as we design the future of our quality of care reviews here in Scotland. So absolutely delighted to have Tracey on the call. Good afternoon, Tracey.
Ryan, and hello everybody. Firstly, thank you so much for inviting me to talk. And I feel very humble, because I'm sure all our friends who've joined from different parts of the world are far more expert in this area than me. I thought it would just be helpful perhaps to share some personal thoughts around the challenges that we face globally before perhaps we head and land down in Scotland. But firstly, a big congratulations to Julia for winning the prize. I'm glad you couldn't see those who didn't know what the flag looked like, so apologies to friends. If I may, I was asked to talk about, particularly from a Scottish context, considering the relationship around scrutiny and quality improvement at a national level. My hat has been the last number of years working very closely with ISQA, as Brian just mentioned, the International Society for Quality in Healthcare. And we've had the pleasure of working with many countries around the world. And what's becoming increasingly apparent is the strength of any one health system that has a particular country name is completely interdependent on the strength of health systems that may be a couple of thousand miles away. I thought it may be helpful, just to begin with, to perhaps share with you a bit of a 35,000 feet whistle-stop tour around where we are globally today from a population perspective and a health perspective, and reflect on what's coming down the line globally around some of the challenges for us as global citizens, and then land smoothly, with no fog, hopefully, into Edinburgh Airport or perhaps Glasgow, and just talk about some of the reflections of the fantastic strengths that you have in Scotland, mindful that we've got some colleagues particularly joining from Scotland. So that's okay, I'll just proceed through on that basis. So the world today, this is a beautiful photograph of Ban Ki-moon, Director General UN, back in October 2011, celebrating the birth of the 7th billionth baby on planet Earth. So as we sit today, we're around about 7.4 billion, so we've grown quite substantially since that time. By 2050, we'll be around about 9.5 billion, and by 2100, about 11.2 billion. And it's worth considering that if we have any friends from China or India joined this call, that just over a third of the population is actually comprised from just 2 countries, from China and India, and that whole proportion of where the population is in the world will change over that time, with some significant growth in certain areas that I'll come to talk about. So hopefully you can see the slide before you. It looks very complicated, but it isn't. On the left-hand side, vertically, is female life expectancy at birth in years, and at the bottom is male life expectancy. And this is just demonstrates the different life expectancies across the world. What you have along that line in the middle are a series of circles, and the circle reflects the population, and the colour is coded according to different regions, and there's a little square that shows that. So not surprisingly, you see at the bottom left a lot of grey countries, which are mainly parts of Western Africa, but Africa as a whole. The large grey area in the middle is the world on average, so you can already see the inequalities there, through to the top end, which are our friends in Japan and Taiwan. And I really don't know what Monaco is doing up there, but there's a little Monaco just to test if somebody's reading it. But it just shows that this snapshot, which was 2011, it hasn't really changed much. If you look at an angle, the inequalities that exist currently based on the size of the populations that exist in those countries. So as we look then to what have we been doing as a world to try and reduce those inequalities, many of you will be aware that in 2000 the UN convened an approach to say, here we are, planet Earth, what do we do to try and improve some of the quality and safety that's going on across the world? I established what we'll call the Millennium Development Goals that finish at the end of 2015. There are 8 goals. I'm not going to go through them, but I've highlighted the 2 that are particularly relevant to us when we think about pure healthcare and quality and safety, but argue all of the 8 are relevant in some way. One of the big targets to try and reduce some of the avoidable harm and deaths were at reducing mortality of children under the age of 5 and reducing maternal mortality, with some significant discrepancies across the world. So how have we done? Well, up to the beginning of this year, this slide is just showing some of the amazing improvements around maternal mortality, particularly in some of the sub-Saharan Africa countries. So actually a lot of imports from those countries and a lot of donor contributions. The maternal mortality has actually reduced by 47% since 1990. But tragically, it's still 15 times higher in developing regions than in developed countries. So still substantial gaps for us as a globe to try and address. In relation to the death of children under 5, again, nearly 14,000 fewer children dying each day, beginning of this year, compared to 1990, which is fantastic. But there are 6.9 million children who still die each day before their 5th birthday. So a lot achieved, but as a globe, still a lot more to do. So that means for going forward as far as the global population, and what are our priorities as a globe after the end of this year, given that the Millennium Development Goals finish at the end of this year. So over the last 10-20 years, there's been a particular focus trying to forecast through what does the world look like. I showed you that 7 billion slide of population in 2011. But if you look at the slide before you, this is the projected population growth from 2010 to 2100. So this is the snapshot of the world, and particularly the lighter colours the light cream is a negative, so population is likely to shrink a little, and the darker the colour, the larger the growth in population. So if you think of the slides I've just shown you about maternal mortality and deaths of children under 5, as I'm sure you're aware, the worst mortality is, as I said, particularly around sub-Saharan Africa and some of the Southeast Asia. And if you look at this, that's where the population growth is going to be quite exponentially increased over those years. So what is it that we as a country, as we sit today, and what is it that we as a globe need to concentrate on? And I'm going to explore a little bit about why it's relevant for us in a moment. And you start to project through the global population. I'm sure everybody on this call is facing some of the similar challenges of how do we care for our older population better. In Wales, I'm sitting in Cardiff at the moment. 1 in 2 of our population of adult age have a diagnosed long-term condition now. And if we retire at the age of 65, some of us may live another 20 years, maybe living quite healthily over that time. So how we deal with an ageing population is a significant challenge for many of us. But what to be also aware of, this graph before you shows the relationship between children under 5, between 1950 to 2050, which is that red diminishing line, and people over 65. This is across the world. So one of the challenges for us is that we grow old, live old to a longer age, which is great. We don't have the same number of children being born to support us when we get old, to pay taxes that help fund the long-term conditions that we may get. So this really, for me, this slide just exemplifies why we have to work with people to help them stay healthier for longer, because we really have to reconstruct how we provide health and social care services going forward. So what about the Millennium Development Goals? And I said they finished at the end of this year, so a lot of work's gone on in the last couple of years to say, so what are the global priorities for health and care to be for the next 15 to 20 years? In September, and if it's helpful, Brian, I'm very happy to send a link if people don't have it, but the future post-Millennium Development Goals, referred to as Sustainable Development Goals, have now been produced and approved. This isn't a very clear slide, so apologies. But there are now 17 global goals, and it's interesting that we've particularly referred to sustainability, because the population changes, the population grows, we're in a situation where the resources that we have are perhaps in the wrong place. Actually, the strength of a country in Sierra Leone is particularly as important to us when we think about emerging threats. So I'm not going to go into these in detail, but just show you the two that are perhaps more relevant to us on this call. One is about good health. For me, I'd like to know that there's just as good health that's happening in Brazil or Africa or India when people are mobile, getting on a plane, moving, or in the UK or North America, likewise. And similarly, I've also highlighted reducing inequalities. I showed you that chart around life expectancy across the world. And as I sit, we have 19 years difference in healthy life expectancy between people living in areas of high deprivation and low deprivation, and that may be as far as 7 miles. So we're all challenging with inequality. So it's how we try and learn from each other to try and address this. And this is really part of the whole sustainable agenda going forward. And I would sincerely suggest they're worth going through and reading. Many countries are now looking at how they adopt those. So before I get into landing back into Edinburgh, with my ISQA hat, I wanted to just share some of the trends of the conversations we're having with people about how health systems need to adapt and how they feel they need to strengthen going forward. So obviously economic slowdown and austerity is rearing its head. As much as we try to back it down, it's very prevalent and increasingly prevalent in perhaps countries that we wouldn't expect. And that obviously has an impact around health budgets, social care budgets, welfare, and people's ability to make different choices in their own lives. Globalization of disease is a big challenge for everybody, and I'm sure everybody on the call is aware of the challenges around Ebola. With my day hat, we are the response in Wales and work very closely with the UK and the WHO around preparedness for emerging threats. But certainly we would say that it has had to air travel and globalization of diseases what 9/11 did to travel. It has changed homeland security around safety. So it is to our all vested interest that we support countries who don't have strong health systems, because actually it takes 6, 7, 8 hours to move around some areas in some countries that may be more challenged. So that has really focused our mind globally. Urbanisation, I'm not going to dwell too much on this, but we've got metacities that are evolving, that have challenges around communicable disease. Again, the whole mobility agenda means that that's not just homegrown, that has potential to have effects elsewhere. And most importantly, I think the ageing population. I've suggested this earlier, but by 2050, the world's population of 65 will approximately equal the world's population of children under 14. So we have a little bit of like a workforce plan. We have a human plan, of demographic plan that we really need to get on top of to see how we govern and run our health systems. From a population health perspective, again, many people will be aware on the call that the focus around universal health coverage, meaning any member of a population in a country has an entitlement to access healthcare, whether through a social taxation system or private health insurance. But the tenets of universal health coverage at the moment have been very much driven to support the strengthening of health systems, particularly in South America, in Africa, and in particularly Southeast Asia. But it's something that is a particular area, and I'm sure Scotland has been involved in supporting other countries. Inequalities I've mentioned, as I say, it's something that's homegrown to all of us, not just globally. We've moved very much into conversations with a meeting with colleagues in China in a couple of weeks' time, and the sole conversation is how they strengthen through accreditation, through scrutiny, through licensing to drive quality improvement. That will look different in China than it does to Scotland, no doubt, but South Africa is doing the same, Brazil is doing the same. So this is the whole way we scrutinise and assure in order to support universal health coverage is a growing area. And finally, informed decision making. Many of us spend a lot of our time saying, why are we doing things that we know the evidence doesn't support them, or in fact we know are causing harm? So how do we share globally and in our local jurisdictions to ensure that we're adopting evidence-based practice? And from a municipal perspective, that's something that is being asked of us on a regular basis. The final point, technology. We have friends in some of our African countries that are exploiting technology so much faster than some of us are, for example, in the UK. So there's amazing learning about how we can really exploit modern-day accessible, fast-paced healthcare in a way that some of us are just not familiar with, and big learning for us in that. So what does that mean then as far as by 2050 as a globe? Well, in summary, that we'll be in a situation where, as I said before, people over 65 will equal those under 14, a substantial increase in people over 50. What does this mean to retirement age? What does this mean to pension systems? What does this mean around the whole of prevention agenda, because we can't afford ill health in the way that some of our health systems are run at the moment. Population dynamics is changing, both locally and in different countries, and there are significant trends. Obviously, we're all aware of some of the refugee crisis happening at the moment. That affects all of us. So as I said at the beginning, as we sit in our respective countries, the world is very small. So trends that occur in different parts of the world do have effect in our own countries, and the situation now about really how do we support each other to provide a much stronger, resilient health systems across the globe. Just before I get into Edinburgh, Scotland. Apologies for other people outside of Edinburgh and Scotland. I just want to show you one slide. This is I think a really insightful slide. This is from Fitch, and this is a slide that was produced in March of 2013. And on the lower left-hand side, as you'll read, it says the number of Australians aged 65 or older relative to the number of working age. So back in March 13, it was 20%, so probably similar to some of us on the call, and that by 2050 that would be 39%. How when you look at the relationship between public debt as a consequence of the ageing population, by 2020 in Australia it's forecasted to be 4.4%, and the story behind this slide was if nothing was to change around the way the health system was delivered, it might be interesting if we have any colleagues from Australia to perhaps contribute to this, that by 2050 that percentage of debt is 144%. And we've been using this slide in Wales and with colleagues in the UK to say we have to do things differently. This has to be about helping people stay healthier for longer, whether that's through scrutiny, whether that's through quality improvement, whether that's social policy. So we really have to, it's not just about how we treat people with diabetes, it's how we fiscally look at changing the way that we do things so that we've got healthy people who are ageing well. Okay, so landing down then smoothly into Aberdeen Airport, and I've chosen this slide. This is a slide for people who haven't been following the World Cup, where Scotland hammered the US in rugby. Apologies if there's anyone from the States. And should have won the World Cup, playing Wales in the final, obviously. So I thought I'd just put that up. So I was asked to talk about the relationship, as I said, between quality improvement and scrutiny, and I wanted just to set that in the context that any approach to a national improvement in any country at the moment and how the levers and drivers work has also got to pay some due consideration to what's happening and the trend elsewhere in the world. As Brian said at the outset, I've had the great pleasure of working with some fantastic people in Scotland, and we've been engaging with lots of people in the health system, social care system and the public, and patients looking at how you want a quality of care review process to work and align to what's appropriate from what the fantastic things that you're trying to achieve in Scotland. And I always think it's useful to remind ourselves the reason why we all want to improve the quality and safety of the services that we provide. And often we're focused in some countries by the front page of a newspaper, or in Wales at the moment it's about the front 10 pages of the newspaper and the challenges that we face. But we're not facing these on our own. The challenge that we all face is because we're humans and we behave and we can be awkward and we can be innovative. But it is just worth just looking up and just perhaps thinking about the context around patient safety and what we're trying to achieve in Scotland and what we're trying to achieve in our own respective home countries. So you know all this, but perhaps just to say a reminder before we go into talking about high reliability healthcare systems. So in developed countries, this is us, many of us on the call, others perhaps who aren't from developed countries on the call, but about 10% of patients may be harmed while receiving hospital care. And not to look more broadly in other countries, that the risk of healthcare-associated infection in developing countries is up to 20 times higher than in developed countries. And we have some real challenges in those of us who are living in developed countries. It's a really concerning statistic. This is 2 years old, to be fair. I don't know what the most up-to-date is, but in some countries, the proportion of injections with reused unsterilised needles is up to 70%, and unsafe injections cause 1.3 million deaths annually, and 2 years ago there was 300,000 deaths in India as a result of this, and some of these things some take for granted and others are really trying to improve. And more than 50% of medical equipment in developing countries is unusable or only partly usable, to the extent that, you know, I was in a country a couple of years ago and providing healthcare in a resuscitation environment was the challenges of grappling with sharing a ventilator with whoever was being anaesthetised to go into theatre. So, you know, how we adapt, how we provide good, safe care, all this looks different in different places. And finally, I'm sure people are familiar with this, and I think this is something that we really should never forget, that should drive us to continuously improve. 1 in a million chance of a traveller being harmed in an aircraft, 1 in 300 chance of a patient being harmed due to healthcare, and that's an average. So that's really, I guess, why we come to work, to try and reduce that variation or that avoidable harm. So just focusing a little bit around scrutiny, and for me the ethos of what it is about. And as Brian said, I had the pleasure of been involved in setting up a regulator in Ireland before I came to Wales, so we lived and breathed it really. And I guess I'll come on to some reflections on lessons learned. But key ingredients of good scrutiny, good accreditation, good regulation are exactly the same as the key ingredients for providing good, safe services. It has to be about safety. It has to be about recognising and stimulating quality. It has to be about reliability. Reliability, what I mean by that, we all have perhaps different definitions, is that we provide the same high standard of care every day, everywhere within a country, so that it's reproducible, and whoever I am needing care by a GP or in a social care setting or in a hospital, I get good, safe standards Sunday night at 2 o'clock in the morning, in the same way as I do on Monday at 9 a.m. Culture of learning, so how does scrutiny, how does external assurance want to help promote and assess the culture of learning in an organisation? Decisions are informed based on population needs, based on that clinical risk of that patient, that person that's in front of you, not based perhaps on the bottom line of a decision maker by a director of finance, when actually the whole purpose of providing good, safe services is the assessment of need by that individual. And of course, it is all about the patient. So to me, those are the principles of for a regulator, for a scrutiny organisation, for accreditation agency. They are no different. So when you get involved, those of us who are involved in have been involved in scrutiny, and it's tough whichever perspective that you're looking at. People, I think, feel that, and some people do, want to just see the glossy procedures, policies, the control charts, the run charts, the controls in place around the corporate governance of the organisation. And that's obviously really important so that people know how work is done around there, but actually the systems and processes are only as good as the people who work within them. And whether providing services or receiving services or scrutinising services, it really has to be about how communications take place between that professional and that patient, between that member of the public and that board member, between that orthopaedic surgeon and that nurse in the ED. What are the relationships like? We know where relationships are poor, patient safety is harmed. People treating each other and most importantly treating patients. We know that where multidisciplinary team working is ineffective. We know particularly that has an impact on patient safety. A hospital not far from here, actually, I wasn't in Wales at the time, the cardiothoracic services closed for a week. It didn't close because the roof was falling in a theatre or because there was a communicable disease that they couldn't get on top of. They closed because the relationships between the surgeons, the anaesthetists, the theatre staff and the ward staff were so toxic that it's actually dangerous for patients. So how we interact with each other will have an impact on the way that we provide services. Leadership, which I'll come back to, but really this is about the culture, and it's difficult to capture the culture of an organisation. And of course it's incumbent on the leadership, be a porter leader or chief exec, to really ensure that the culture is all about the patient. Really it's a test of the DNA. What does it feel like when you walk into a hospital or a GP surgery or a care home? That says just as much about the culture as the policies and procedures that are pushed across the table when somebody is scrutinising an organisation. So that, to me, those are the absolute heart of the principle of what good should look like. And the essence of this is leadership, and how we scrutinise in a way that gleans the strong leadership, but also how we run reliable health systems is about identifying the leaders of the future, not by job title, but by passion and capability, so that we can really invest in our own across health and social care to ensure that patients get the best care from the best leaders that they can possibly be. From a scrutiny perspective, which I was asked to talk about, bearing that in mind, that has to be the horizon of what should be the compass for any scrutiny organisation. I think the principle that it's about the patient, not the organisation that one is engaging with. that external assurance of any or external evaluation of any means, be it accreditation or regulation or scrutiny, is part of the improvement system. It's a key player. It is there to ensure that it can help build capacity and capability in a system to continuously improve. But it has to be risk-based and proportionate. It is not about the act, it's about how people can be enabled to continuously improve care. And we've seen examples of very much over-constructed engagement that it actually is dangerous in its own right. So how can it be risk-based according to the earned autonomy of an organisation and proportionate to the needs? Consistency is really important. It should be the same experience, same expectations for the public and providers wherever you are, whether it's an accreditation organisation in Jordan or whether it's Healthcare Improvement Scotland in Aberdeen or Edinburgh. This has to be about clear expectations. It's not about catch-out. Patients and the public should be absolutely clear what they can expect, and the providers should be clear what's expected of them. Because this, after all, this is all about enabling improvement, not trying to catch people out on a day job. I've witnessed a lot of poor experiences and been on the receiving end also of poor experience, and it's not just perhaps the bipolar of what good looks like. Inconsistencies in assessment, in judgment, the word unfairness starts to be bounced around, that an organisation that's a custodian for the public, be it an accreditation organisation in Kuala Lumpur or a CQC, Care Quality Commission in England, how we respond to concerns from staff or from the public or from patients is key. One that organisations that externally evaluate have let themselves down is the credibility of the people who are working with people on the ground, which is absolutely fundamental. So the credibility, the experience that people come with, and particularly the training is, as I say, absolutely fundamental. Also, exploitation of power. Any organisation that is providing external assurance is just an organisation that's got a role and responsibility about improving care. It's not there to exploit powers. And so the culture within an organisation that is scrutinising, I think, is just as important as the culture within providers that are delivering good, safe care. And how a scrutiny organisation, I'm looking here because I want to say improvement organisation, so I don't see the difference, engages with the public, engages with the media, engages with staff in an open way is absolutely key. So just, I guess, some reflections around lessons learned in the world of more regulation, I guess. And reminding us back to the approach that any scrutiny organisation must take has to follow the good principles of reliable healthcare. That it has to be that the culture of that organisation that is doing external evaluation it has to be an enabler. That's what it's there for. It's to enable people to be aware of the quality of services. It's there to enable recognising best practice so that it can be shared. It's there to enable improvement where that's needed. It is a key driver for change and improvement, not an endpoint in itself. I think there's a real opportunity also that organisations that are scrutinising, they can engage around outcome frameworks, that there is one single common coherent language of quality that is owned by people providing services. It's the same kind of language of people who are scrutinising services, and it's the same kind of language that gets into policy. Makes life much easier to try and bring about that a galvanised journey of improvement. It has to be about working with, not doing to. Organisations like this are just organisations within a health and social care system. There's no hierarchy there. It's about working together to discharge responsibilities for good, safe care. And I've written the intended consequences, and just to say that I think we all know, perhaps through the eyes of key performance targets or standards sometimes, all the way in which an organisation is scrutinising puts emphasis on one area and perhaps not another. There are always unintended consequences that they skew where the spotlight is, and unfortunately sometimes that distracts from where the spotlight should be. So the unintended consequences of what is often a focus on something that's of concern sometimes creates risks in other areas, and I think it's really incumbent on people who are working in such organisations to be very, very well aware of that. And really, it is always and only about driving quality, enabling improvement, and safeguarding people. That's what I say. That's the right. So finally, just some reflections. As I said, I've been really, really enjoyed. I'm very, very privileged to be working with colleagues in Scotland with the exciting journey that you're going through, not only in the improvement agenda and the wonderful stuff that's happening, but also in your health and social care agenda and where you want to be around quality of care. Who are not as aware, and if I'm right in saying, Brian, as of April, embarked on a major integration of health and social care across Scotland, which will bring benefits for people using services. So again, some opportunities for Scotland, and apologies for people who are not sitting in Scotland at the moment, but perhaps there are some reflections there for everybody. I think from a Scottish perspective, you've got a real great time around learning from others and get the balance right. This isn't about power, this is about different organisations and people having different responsibilities, but the purpose is the same. And the outcomes are about patients, not organisations. I think you've got a great opportunity because, particularly in Healthcare Improvement Scotland and all of your improvement fellows across Scotland, that have a hand-in-hand relationship, the click of scrutiny and improvement, and a managed handoff of relationships, so that all of those different levers for improvement are working together to support people who are interacting with patients every day. I believe I said earlier that your integration agenda really enables you to work closely with the Care Inspectorate, Healthcare Improvement Scotland, also to look at people's journeys in an area. What's it like to be an older person in Glasgow? What's it like to be a younger person in Edinburgh? What does medication reconciliation look like between hospital, primary care and care environments? And that will enable you to do that even more. You've got a great opportunity, as you always are doing anyway, in just continuing to build capacity and capability, but through the way that you scrutinise. This should be about harvesting experience, being involved in the activity, going back into their organisations, learning and sharing. And finally, your opportunity to really embed approach in the way, purely being the way that you do things around here. And so that where an organisation feels they're at and where a scrutiny organisation assesses them to be at, that gap is negligible, true reliability. And you really, frankly, have all the opportunities in Scotland to do that. So thank you very much for your time. I apologise, that was a bit of a global whistle-stop tour landing in Scotland, and perhaps just to remind the connection with what you're doing in Scotland and colleagues from different countries. It's gone are the days where we can set policy and strategy and structural change in countries without being mindful of what's happening in the rest of the world. And so I'll stop at that. Thank you.
Wonderful, Tracey. Thank you so much for an amazing talk. As you say, it took us from global health, comparisons in global health, comparisons in safety, and then back to the UK and back to Scotland. I noticed you mentioned Scotland's second city, Aberdeen, its third city of Edinburgh, and only one mention of its first city, Glasgow, but we'll let you off with that. Okay. So listen, what I'm keen to do is on to the questions, and as I introduced earlier, we have Winnie Burke, Strategic Inspector, the Care Inspectorate, who's going to be asking the first question. Welcome back, Winnie.
Thank you, Brian. Firstly, can I say thank you, Tracey, for a very informative and very interesting presentation. You spoke about the principles of scrutiny, and I would hope that ourselves as the Care Inspectorate and Healthcare Improvement Scotland all subscribe to those principles of good scrutiny, and we've certainly been continuing to look at those on a national basis as we move forward in our scrutiny of health and social care partnerships. We're at the very beginning stages of our scrutiny of health and social care partnerships, and I just wondered, Tracey, at this point of transformation, how do we as scrutiny bodies help to drive change, ensure that it's led by the health and social care partnerships as opposed to being driven by the scrutiny process?
I think that's a fundamental question that that many countries pose, and I think some answer the question well and others don't. To me, it's about using the assets together you have in the country, and I mean within just the Care Inspectorate and Healthcare Improvement Scotland. You have, what, about 5 million population or so. You've got experts right across the country in health and social care. So some of those are professionals, some of those are patients and service users. So if you can shift to an approach where you're look through the lens, always through the lens of improvement, but the people who you are using are lay people, are people who are employed in different parts of the country, who are participating in peer reviews and go back into their organisations. You start to learn both ways and embed an approach, build capacity and capability that is about people owning the focus around quality and safety, rather than being on the receiving end of perhaps the for Care Inspectorate and Healthcare Improvement Scotland. So I think you really do need to harvest the people that you have in the system, experts in their own right.
Thank you much for that.
Thank you, Tracey.
Any further thoughts?
Thank you very much, Tracey. That's very helpful.
Thank you very much, Winnie. Now, Tracey, the chat box has been buzzing. So one of the areas that came up from a number of people was the business of how scrutiny and improvement work well together, or do they work well together? Jason Leach, known to many, National Clinical Director at Scottish Government, highlights the click of scrutiny and improvement and liked the handoff of the work that you described. Jackie Welsh from Quality Improvement and Assurance Coordinator in Ayrshire and Arran also had a comment that listening to this group, even as we have this debate whether there's too much emphasis on scrutiny and not enough support of improvement. So is there too much emphasis on scrutiny enough to drive improvement?
Well, I think the essence of it is how you scrutinise, firstly, because I think scrutiny has to be about improvement and not about catch out. So it is all about helping organisations move from where they are to perhaps where they want to be, not about punitively assessing or judging compliance, and I use that word deliberately at any given time. I think the handoff is fundamental, and I was up in Edinburgh on Thursday, in fact. We had a design panel meeting, and we were just talking about the relationship and where it could move to. I'm just talking for a moment around Healthcare Improvement Scotland. So you have fantastic quality improvement capacity there, and you're also an organisation that scrutiny, but scrutiny could be called improvement in its own right. I'm talking about the opportunity that you have, and these are my words, so apologies if people may or may not agree with them. But some countries have moved to a more relationship-managed approach. So you can have a QI lead that's a relationship manager with any of your healthcare organisations, and when a scrutiny activity is kicking off, then that improvement person is working with that organisation, starting to put together what an improvement plan would look like, and then tailoring the support that Healthcare Improvement Scotland and others can provide that organisation. And that, to me, that's the handoff. That's just different functions that are all about levering improvement and recognising that actually you do need a bit of a firewall around that. In my former world, we did a number of things, including health technology assessments, but as I said, we also regulated. We were organised to establish a Directorate for Safety and Quality Improvement with the IHI and establishing the firewall, because if you can respect the boundaries within the organisation and the credibility that people have with providers locally that you're also scrutinising, actually the wisdom and the knowledge and the sharing and the dissemination of good practice really come together nicely to help that provider. So I think that handoff is a way that, with the revision to your quality of care reviews, I think you can design that into it in a way that you use those assets that you have joined up, that click, as I said, of scrutiny and improvement resource, almost about the same thing, in a way that other countries haven't been able to.
Thanks so much, and that goes to the question that was raised by our very own Jennifer Graham, our clinical coordinator, about the strengths and downsides of having scrutiny and improvement support within the same organisation. You highlighted the way that you design it and the way that it's carried out is important.
Yeah.
Great comment and question here from Elaine Mead. Elaine's the Chief Executive at NHS Highland and a real QI connector from the very outset. Elaine says, inspiring presentation, thank you, Tracey. She goes on to say that integration of health and social care as easier than integrating health and health. How can we drive this integration more effectively and even more quickly?
Oh, you could be sitting in Wales, Elaine. We have the same challenges every day. I think that's really interesting. It's a difficult one. I guess my instant response is that it's all about relationships, and the speed in which that integration will happen, as we all know, on the ground will vary according to the mutual respect of the relationships locally between health and health, but with health and social care. I'm a great believer that I know you've got structural change going on and you've got new governance going on, agreeing to do some new specific work together that traverses the boundaries of health and social care through the lens of a person, to people particularly looking at long-term care, looking at the care settings, looking at the experience they have in an acute setting in primary care, and actually designing a group that actually oversees across health and social care with members of the public and professionals to really try to design in a new model that is about change, but it's co-designed and co-produced across health and social care. But at the end of the day, Elaine and Brian, I guess people have got to want to work at those relationships to make it work. And I think from a national perspective, I can see that dodgy Jason Leach making comments how Scottish Government can help support that and how the leaders across health and social care can support perhaps areas that are slightly challenged at the moment. It's going to be key.
Right, dodgy Jason Leach down many times. Elaine just finishes off by saying that she loves the quote you've just given her. It's always and only about driving quality, enabling improvement and safeguarding people. It's about relationships. So much for that. We have Fiona Montgomery, who's Deputy Director at Scottish Government, mentions that scrutiny as a word, and scrutiny has quite a negative image. It feels something that's done to you. Edward James, who's a consultant microbiologist at NHS Borders, goes on to say, what work goes on to recognise the unintended consequences of scrutiny?
Two different things. I completely agree that scrutiny is a terrible word. I hope suggestions is better words, but you have an opportunity to use the word that describes what you want to do, I guess, at this point in time. And you've used scrutiny historically, but maybe now's an opportunity to say, well, what words create a view of the culture that you want that interaction to look like. And scrutiny is always a bit of a hierarchical, judgmental word. So, I would just kind of put it back to you guys, and Brian, you've got an opportunity to change where you would want to. So that really answered that question, didn't it? As far as unintended consequences, I think that's a really, really important one. So, maybe give you an example. In a former world, there were in England lots of key performance targets for many aspects of healthcare, and the only scrutiny is also about performance targets, by the way, not the act of external assurance. And we noticed as an improvement organisation, that was when at the time, together with the regulator at the time, that we were having a run of serious internal incidents, avoidable deaths, serious harm, growing across a number of different obstetric units across the country. You step back and try to identify why was this trend emerging. Now, I'm saying that this was causal, but there were key performance indicators for the majority of services. There was nothing for maternity services. The only thing that was there was what was called at the time a clinical negligence scheme of trust, which had some basic standards around maternity. And we actually, with the organisation at the time, we actually did a little piece of work with health boards and looked at the focus of what is actually one of the highest risk services, as we know. There was no focus, very limited focus, and quite frankly, the eyes were off the ball because they're all in different directions. So we ended up in a situation of really having to try and really put a lot of improvement work into obstetric services, in spite of the fact that these are high cost, high harm. And what a board is seen to be monitoring suggests that that's what it deems to be important. It wasn't important to boards because the boards won't be asked for their performance in it. So as a form of scrutiny, we all have to be very mindful of that. I'm also mindful, just very quickly, of former world. We did a lot of investigations for some concerns that we had, as every country has, and we did a run of investigations into breast cancer misdiagnosis, and all of a sudden the only cancer activity was for breast cancer. So we had to step back from that and say, actually, they still have a requirement to provide the services that they need to for across all different cancer types for patients. Just we've put a lens and a microscope shone in one area. So you just need to be mindful of our actions, that when we light a torch somewhere, people look. And sometimes you only want some people to look, and you want others to be focusing on what they should be doing. So it's more of an over-understanding of making sure that we don't create more risk elsewhere by not managing what we're doing.
Thank you very much for that. Now we've got time for one more question, which I'm going to put to you, but I won't put to you the comments. So there are a number of comments which could have led into a discussion around the future workforce. So thank you to Alison Gilhooly, Programme Manager at National Services, and others who commented about the future workforce. But I'm going to take you to a theme of questions around the patient and the patient's role, and the public's role, in fact. And delighted to have Cam Homa, who's an improvement specialist at the Dartmouth Hitchcock Medical Centre in New Hampshire in North America. And Karen says relationships are important to improve between distance, but also considering the relationship between provider and the patient or family. This interaction is key in creating good care. And Edel Sheridan, who's project officer here at Healthcare Improvement Scotland, raises what might be done to support patients and the public to become more empowered towards self-management.
Thanks, Karen Adele. I think it's fundamental. Back down to principle number one, it's about patient and not patient experience, patient outcomes, not the organisation's outcomes, because they should be the same. Karen, you'll be familiar with Planetree, I'm sure. There's some excellent examples, really, of organisations that have been established by patients or carers because they've been so frustrated that they're not being listened to by a health system. And certainly the push and the focus that's really starting to gain a lot of traction at the moment to align the focus from board to ward. It's not only looking at the patient-reported outcomes, but also patient-reported experience measures. And in order to answer that question, it drives you to have to, whether it's ingrained in the culture of an organisation or not, it's about the patient. So how patients are engaged and their experience just proactively on a ward, in a practice, in a care setting. It drives you to have those open conversations with people about how did you experience your care here? Is there anything that we can do to improve? Because it isn't just about outcomes, it's also about experiences, as we know. So I think on one level, Brian, there are some really good examples, and maybe we can put those through this network for people for the QI Connect, of organisations that are really starting to make some traction and providing guidance for people, because certainly many organisations say we want to do it, we just don't know how to, and my response is we'll just go and speak to people. I think secondly that the active seeking of views and active listening of people's thoughts and contributions in the planning of services, in the way that you design a care environment, should be mainstream. It shouldn't be a consultation tick after the fact. And at the end of the day, it's cultural. And I do think, backward scrutiny, and I agree it's not a great word, that they have a role to play to help drive their organisations, particularly those who are more reticent to do so, that actually the bread and butter of what they're there to do, their customers are patients or carers or service users. So you have to be able to demonstrate how that is living and breathing in the organisation, but people need guidance. So perhaps one of the QI Connect follow-up would be perhaps to signpost people to organisations that are doing some fantastic stuff that can provide some hardcore guidance for organisations that are struggling.
Thank you very much for that, Tracey, and we'll make sure and follow up with some of those organisations in the material available on the website. And a thank you to Karen from Dartmouth Hitchcock, who of course is our Centre for Shared Decision Making, is going some way to lead in this field. Tracey, it's been a wonderful session. We didn't get to the discussions that Sarah Twaddle, our Director of Evidence, was wanting to get into around some of the cost effectiveness and how we stop some of the waste in developed countries, what we've done from developing countries. And neither did we get to Bruce McCullough, the Improvement and Development Manager from NHS Shetland's comment about the central role of organisational development. So I'd like to thank you, Tracey, for a wonderful session. Great chat. Thank you for all the participants. And thank you, Winnie, for leading the way in the questioning today.
Thank you very much.
Just to recap, folks, that's 2015 over, not just yet, but this is the QI Connect series for 2015 over. David Grayson started off the year talking about the experience in Coabatea and mobilising communities. We heard from Beth Lilia around engaging society in healthcare and health improvement and health improvement. We had a wonderful session with Bob Wachter on the digital doctor and the hype, but also the promise of technology. We had a great session with Professor Martin Marshall about improvement science and quality improvement in general practice. An outstanding session from May Dixon Woods about the reality of the messiness of life and why it's so tough to improve patient safety. And a session from David Mates talking about the Canterbury journey in New Zealand around integration. A wonderful session with our friend Maureen Bisignano around health and social care integration, pointing to some examples in Scotland and further afield about the importance of communities, and just such a thoughtful presentation from Professor Paul Batalden a couple of weeks ago on the value of health and social care and the contribution towards health and well-being. And then we have today Tracey's global look and coming straight back to UK and into Scotland and helping us to think through the balance between improvement and scrutiny. I'd like to thank all of our speakers and all of the QI connectors. However, we're looking forward to 2016, and breaking news, we just heard today that Dawn Berwick is our first speaker on QI Connect for 2016. The team have got a great lineup for 2016. We're going to be focusing on the themes of integration and innovation. Integration and innovation for 2016. More information to come, but Dawn is a great friend of Scotland and great friend of improvers around the world, and is absolutely delighted to be our first speaker. Send out more details in due course, and in the meantime, thank you all for coming together. Stay connected with us at HSQI Connect. Have a great rest of the day. Thank you very much.